Dear audience, dear chair, good morning. Let me introduce you the title of my PhD thesis, which is about diabetes mellitus and its effect on oral complications. My name is Bulcsú Bencze. I'm a third-year resident at the Department of Prosthodontics and a second-year PhD student in the Translational Medicine program. My supervisor is Daniel Vég, my SMS is Bulcsú, and our statisticians are Bencze, Szabó, and Gergely Agócs. My vision is to provide adequate dental treatment to the systematically compromised patient, focusing particularly on prevention and prosthetic rehabilitation. In order to achieve this, we would like to find and provide scientific evidence in the possible correlations between diabetes mellitus and oral complications. Currently, we have two ongoing projects. Both of them are systematic reviews and meta-analyses. I have started my first project at the September 2022, and it's about the investigation of the effect of different HbA1c levels on the severity of dental implant complications. It's a very important topic because currently there are more than 400 million patients living with diabetes mellitus worldwide, and it's projected to increase by an additional 100 million patients by the end of this decade. Patients with the disease tend to lose twice the amount of teeth compared to the systematically healthy individuals. This could be partially explained by chronic hyperglycemia, which impairs bone healing, blood circulations, and they increase the formation of glycated end products. These products can interact with the receptors, which are called RAGEs, and they release pro-inflammatory cytokines, the likes of interleukin-1 beta and TNF-alpha. All of these can be found in the periodontal tissue, which means that diabetes mellitus itself can promote periodontal inflammation, which could lead to alveolar bone loss both around natural teeth and around dental implants as well, which ultimately can lead the loss of these teeth and implants. We can measure a patient's last 2 to 3 months of average blood glucose levels with the help of HbA1c. Therefore, our aim was to find an HbA1c level adequate to provide safe dental implantation without long-term complications. In order to answer our clinical question, we have used the PFO format. Our population consisted of patients undergoing dental implantation. The prognostic factor was diabetes mellitus, and we have used different HbA1c levels for covariates. Our main primary outcome is crestal bone loss, and one of our most important secondary outcome is implant survival. We have done the systematic search at 2022. However, during the review process, it became outdated, so we had to renew it by the April of 2024, and we have found more than 2,600 articles. After doing the selection procedure, we have identified 35 eligible observational studies, and we didn't identify any new observational studies after the renewed systematic search. Now let me introduce you my main outcome, which is crestal bone loss. Crestal bone loss is one of the hardest outcomes to measure dental implant success. It is measured on a standard periapical X-ray between two different points, the implant abutment junction and the uppermost part of the alveolar crest in contact with the dental implant itself. There is a baseline crestal bone loss for dental implants, which is considered to be below 1 millimeter for the first year and below 0.2 millimeters for each subsequent year afterwards. In this analysis, we had around 22 articles included. The effect sizes are mean differences, and the outcomes are in millimeters. The overall outcome is 1 millimeter, which is considered to be both statistically significant and clinically relevant as well. However, if we take into consideration our subgroup analysis, which was done based on the patient's glycemic control, we have differentiated between 8% HbA1c level, below that it's well controlled, and above that it's poorly controlled. Patients with poorly controlled values projected even worse outcomes, which were 1.8 millimeters. And patients with well-controlled glycemic values had comparable outcomes to the systematically healthy individuals. Moreover, we have investigated this association with a meta-regression as well. We have used the individual average HbA1c levels as compared to the crestal bone losses, and we have also differentiated between the follow-up times as well. We have dichotomized the follow-up periods. We have differentiated between below and upper 3 years of follow-up. We have found statistically significant correlation between the values. We can say that each percentage of HbA1c level increase provided around 0.25 millimeters higher crestal bone loss values. And we can say that the mean differences, 22% of mean differences could be explained by the HbA1c value differences. As for the implant survival, we have done the analysis on implant survival, and we have found no significant differences between either of the groups. However, I should note that all of these studies had short follow-up periods, so we cannot really say the effect of diabetes mellitus on long-time follow-up. So due to this, we can only say that diabetes mellitus itself has no impact on the osseointegration of the dental implants. All in all, the strength of our analysis is that we could include high number of studies. We had strict exclusion criteria to reduce confounding, and we could make meta-regression as well. However, we still had very high heterogeneity throughout our analysis, and unfortunately there was no population matching for oral hygiene, so we couldn't account for this very significant confounding factor. In conclusion, we can say that patients with worse than 8% HbA1c level have significantly worse clinical outcomes. Therefore, we can suggest for patients who plan to receive dental implants to do preoperative HbA1c measurements. With this, we can identify poorly controlled patients and patients with underlying diabetes mellitus, and if necessary, we can suggest diabetologist consultations as well. Moreover, we can suggest more rigid biannual prophylaxis for patients with risk factors as well. For research implications, we can suggest that HbA1c levels should be investigated with other risk factors as well, such as obesity, hyperlipidemia, and smoking. And I think one of the most important things to investigate is the effect of HbA1c adjustment on the clinical outcomes of the dental implants. The manuscript status is published. We could publish it at May 2024 in the D1 Journal of Dentistry, which is a 4.4 impact factor journal. Our second project is about investigating the effect of diabetes mellitus on the survival rate of oral squamous cell carcinoma. This is yet again an important topic because head and neck cancers are widely spread malignant diseases all across Europe, with Hungary being at the #1 place in terms of incidence rate per 100,000 capita, which is around 3,000 new cases for every single year. And not only these diseases are widely spread, they are dangerous as well. OSCC is the 11th most deadly cancer group in Europe. In order to reduce the morbidity and mortality of this disease, early detection and prevention is key, and dentists can play a crucial part in it. There is also evidence in the literature that patients with diabetes mellitus have a higher chance for malignant transformations. This could be partially explained by hyperinsulinemia, which enables malignant transformation through insulin-like growth factors, and also chronic hyperglycemia, which helps cancer growth by providing ATP. Therefore, the aim of this project is to investigate the association between diabetes mellitus and OSCC to help in the prevention and survival of the disease. We have yet again used a very similar PFO format to answer our clinical question. Our population consisted of patients diagnosed with OSCC. The prognostic factor is diabetes mellitus, and our main outcome is either disease-specific survival or overall survival. We have done the systematic search last year in July, and we have identified more than 14,000 articles. After the selection procedure, we were left with 140 eligible articles. Currently, the topic is data extraction. We are almost finished with data extraction, and now that our first project is published, we can 100% focus more to continue with this project as well. In summary, I have finished with my first project, and I plan to submit my second project by the end of this year. I wish to submit it at around November. And I have had the opportunity to participate in other projects as well in the diabetes work group. We had successfully completed different publications which are in connection with my PhD thesis as well. And I would like to thank your kind attention with a quote from Friedrich Nietzsche: "Truth tends to reveal its highest wisdom in the guise of simplicity." Thank you.
Thank you very much. Nice presentation as well. Questions?
Sorry, if I may ask, congratulations for your progress. Regarding bone loss, I noticed that some articles recorded as average, some mesially and distal values, some may give 6 values, buccal, lingual. So how did you manage that? Like, took the average, took the worst value?
Thank you very much for this question. This is an important question, yes. Usually in these studies which were included in our analysis, it was either the mean crestal bone loss reported by the articles, or the mesial crestal bone loss and the distal crestal bone loss. So we had these two kinds of reporting of these outcomes, and we have chose to do analysis with the mean values. So when they have reported only the mesial and the distal separately, we have made calculations to calculate the mean value. So we have thoroughly used the mean value in our analysis.
So you divided on two, the summation on two, the average of both readings?
The average of mesial and distal values, yes.
Thank you.
It was a really nice presentation. I just want to ask that I saw that on your first forest plot, the heterogeneity is quite high, so it's 100%, and what could be the reason?
Thank you very much for your question. We couldn't reduce heterogeneity throughout our analysis. This could be explained by many factors. For example, as you could see, we couldn't really distinguish between follow-up time, for example. So we either pooled all the studies that have reported these outcomes, which had 1, 2, 3, or 4 years of follow-up times, or we could dichotomize the outcomes by follow-up time, either upper and lower 3 years. And that could be an explanation for the different values, because more follow-up time resulted usually in much higher crestal bone losses. This is one aspect. The second aspect is what I have said at the limitations is that the included studies had very, very different oral hygiene levels as well, which could influence crestal bone loss values. And also they had used different types of the, implant systems. For example, there is a different crestal bone loss for bone level or tissue level systems. There is different crestal bone loss for cemented or screw retained crowns. So we couldn't account for every confounding factor, so that's why we pulled every value, because this could give a more clear representation of our population as well. However, the drawback of this is that we couldn't reduce the heterogeneity.
Okay, congratulations for your presentation. I would have 2 questions. The first one is about the survivor of the implant. So how heterogeneous was the definition of this outcome? Because it could be really diverse in the articles.
Thank you for the question. The reason that we have used implant survival and not implant success is because implant success is even more heterogeneous, because peri-implantitis could have different definitions, and of course if an implant has peri-implantitis, it would not be considered a successful dental implant treatment. That's why we have used implant survival, and implant survival was actually surprisingly very homogeneously defined. They have just described that if an implant was lost from the placement up to the follow-up times, it didn't survive. However, if it was inflamed or anything specific like that, but it was in the patient's mouth, the implant was there, so it counted as a survived implant.
Thank you so much. And the other question is regarding the crestal bone loss. You said that the 1 millimeter is at the acceptable level at the first year. And what do you think, why is it in the consensus?
I mean, 1 millimeter, yes, it's the uppermost value that is considered to be acceptable. However, currently we do not see that much crestal bone loss anymore, because we have, for example, very different features of implant systems that can negate the effect of the initial crestal bone loss, because they can place the connective tissue closure away from the placement of the dental implant. So I have included this definition because it's still the consensus in the literature. There is no update to that. However, I don't think that 1 millimeter crestal bone loss is acceptable anymore for today's standards.
Totally agree. Thank you so much.
Thank you.
Thank you. I have one question, because the crestal bone loss is a really big topic in implantology. But there is one thing, because we are talking about bone loss, but in front of the bone there is something from an anatomical point of view, and there's the soft tissues. So did you involve this evaluation of the biological width of the gingiva and the soft tissues? Because this is one of the predictable factor for peri-implantitis.
Thank you for your question. Yes, in the manuscript we have emphasized that one of the most important confounding factor is the width of the soft tissue before the implant placement, because if there are no eligible amount or quality of soft tissue, we cannot really expect successful implant treatment regardless of diabetes mellitus or not. However, none of the included studies have measured the quality of soft tissue before implant placement. We have measured the pocket depth and the bleeding on probing as well, so it could give a much more precise picture of the groups included, because, for example, peri-implantitis have a definition not only for crestal bone loss but also for bleeding on probing, pocket depth, and all the other inflammatory statuses. However, we couldn't standardized based on the patient's soft tissue qualities, unfortunately. So that's why the quality of evidence in our analysis became very low. So our results are nice that we have it. However, we are not so confident in our results.
Sorry, if I may have another question. I know that glucose level above 6.5 is poorly controlled. So for the group of people are above 6.5 but below 8, are these considered as normal or treated as normal way?
Thank you for your question. It is a very difficult to assess the situation, because the American Diabetes Association gives two values to differentiate between poor and well-controlled individuals, either 7% or 8%. We have used 8% because every single patient can be placed below 8%, regardless of their life expectancy or comorbidities or anything. Regarding your question, patients above 6.5 HbA1c levels are considered to be patients with prediabetes, so that's why we have grouped them separately. And however, when they reach 7%, they are considered to have diabetes mellitus. However, well-controlled patients can reach almost normal glycemic levels as well due to the new medications. So that's why we have had another table for this to differentiate, to exclude certain groups. So the bottom left table, because there are many groups that have went to the other side of, for example, they had an average of 7.5, but they had such a huge standard deviation that they must have included many patients from the poorly controlled side as well. So we have defined that if a group has a standard deviation which reaches the other region more than 1%, they were excluded from the analysis. So I can say in certainty that patients in our subgroup analysis were truly below 8% or above 8% regarding their HbA1c levels.
Thank you.
Thank you.
Maybe you just answered my first question. So does the subgroups like poorly controlled mean that each and every patient were poorly controlled, or like the mean of the patients in that study indicated that they are on average poorly controlled?
Thank you for your question. The cohort studies included had much more rigid definitions for it. So they have stated that patients below 8% HbA1c levels were allocated to the well-controlled groups. However, in cross-sectional and case control studies, it was not really too specific. So they have said that they have had well-controlled patients and poorly controlled patients, and they have just reported means with either ranges or standard deviations. So that's why we have made that table, to at least be somewhat sure that all of the included study members are below a certain level of HbA1c level.
Thank you. I think Gergő has done a great job. The other thing, sorry, I couldn't help but notice, but that most of the studies are like from Arabia. So are they such pioneers in researching the connection between diabetes and oral hygiene, or what do you think?
Thank you. Yes, I think so, because the first studies that had nice methodologies are from Spain, the Gomez Moreno, and there is another Spanish, the Cabrera Dominguez. So they have started this project, but it seemed that at Saudi King University they really like the idea. So many new studies have arisen from there. But one more important thing is that the population is not always from Saudi Arabia. So usually guys from Saudi Arabia are first author, but the study population is from either the US or from UK or anything like that.
Oh, nice. So then the results can be generalized,
Yes,
like globally.
yes.
Okay, thank you very much.
Thank you.
Yeah, just a theoretical question. Hemoglobin A1C is the standard to evaluate the diabetes, but is there any flow of these measurements? That is, what can change instead of only glucose changes it, but is there any other physiological events which might change this value instead of being a standard? Some people may differ due to some other background.
Thank you for your question. Yes, for example, for certain patients whom have such conditions that their red blood cells damage for some reason, the HbA1c level is not considered to be as accurate as we would think. But thankfully, the American Diabetes Association have a very thorough recommendation to measure HbA1c levels in patients who have such conditions that could change the results of the outcome, and they have different intervals and different values associated with them. So this 8% or 7% can only be used for patients who does not have such conditions, and for patients who have such blood conditions, or they are young, or they are with child, or they are elderly, they have much different recommended values for them. So it's not so easily standardizable, but I think it's still the best value to be used to evaluate diabetes mellitus.
Sorry for being so picky, but now you can teach me something. Why is it a PFO framework? Actually, I'm not that familiar with, but it seems like a PECO, like it's exposure and control. So what does PFO framework mean?
We had many different frameworks throughout our project. So we have started with what you have mentioned, and then we had a PEO framework as well, and we have finished with a PFO framework because we thought that diabetes mellitus is a prognostic factor, so that's why we have used this factor.
So there's not much of a difference, like in terms of methods, but just the naming? Okay.
For us, the methods was the same from the beginning, because our idea was to do this analysis from the beginning, and yes, just the framework changed, but not the methodology itself.
Thanks. Well done.
Thank you.
Can I ask one thing? I mean, this diabetes and cancer, I mean, this is something which was not kind of recognized before, but there are more and more kind of data and thinking and so. So how about other cancers? So have you looked at the literature for meta-analysis, for example, that what's the relationship between diabetes and other types of cancer?
Thank you for your question. Yes, there is many articles in the literature that discusses diabetes mellitus and the effect of it on other cancers as well. The most investigated topic is the thyroid cancer, and they have many meta-analyses and studies regarding that matter. And one more type of cancer is the esophageal cancer, which is thoroughly investigated. And actually, the head and neck cancers are investigated as well. However, there are still no meta-analyses in the topic regarding the survival of such cancers. So that's why, and it's much closer to dentistry, the head and neck cancer. So that's why we have chose to investigate that topic. But there are many evidence in the literature regarding other cancers as well.
During your research in the literature, have you found any diabetes patient-specific implant protocols, or what kind of specific strategies surgeons do in diabetic patient groups? Have you found such?
Thank you for your question. This was exactly the reason that we have started this project, to maybe do something in the scientific field to provoke conversation, to make at least a recommendation for patients with diabetes mellitus. There is no international recommendation regarding dental implant placement for patients with diabetes. And I have read many protocols where they say that diabetes mellitus itself can be considered as a risk factor, which is not true regarding this analysis, because if a patient has a well-controlled value, it shouldn't be considered a risk factor. but other recommendations does not include diabetes mellitus whatsoever. However, regarding the King Saudi University, they have a recommendation for it, and they say as well that patients with poorly controlled IUs should be transferred to diabetologist consultation in order to normalize their glycemic levels before the implant placement. So they have made so many studies regarding this project that they have implemented this recommendation in their protocol.
I mean, frequently we would like to raise the success of diabetic patients to the success rate of average normal healthy patients, and for that reason we frequently select more specific surfaces or more expansive surfaces of the implants, narrower implants, for example, to leave more thick buccal bone, or we especially take care about the attached gingiva on the buccal surface. So when implantologists do such specific therapies, then it reduces a little bit the difference because the success rate is elevated a little bit. But if surgeons don't know these strategies, then the difference will be increasing, I think.
Thank you for your question. We have wanted to investigate that one as well. So to differentiate between patients with diabetes mellitus with screw-retained crowns versus cemented crowns, or tissue-level implants versus bone-level implants. But the evidence became so thin after so many subgrouping that we couldn't really introduce usable information. But it would be very nice to have a recommendation for patients with diabetes mellitus, what type of implants should they use, what type of loading or fixating protocol should be used for such patient, but unfortunately I couldn't provide with such data.
I'm so sorry for asking again, but I really like the topic. I saw that you investigated also plaque index and bleeding on probing. I saw that it is recorded in multiple indices, and some recorded as continuous, some as percentage and present or not. So how did you manage this heterogeneity?
Thank you. We have only included studies that have reported dichotomous outcomes for plaque index and bleeding on probing. Either there is plaque or no plaque, there is bleeding or no bleeding, and the pocket depth was continuous, so it was very homogeneous throughout the studies.
And the plaque index the same, and the bleeding?
Yes, exactly.
Thank you.